Welcome to Vein and Lymphatic University. My name is Lowell Kabnick, and it gives me great pleasure to have Kathleen Gibson as our featured speaker today, who's going to be talking about glue complications, tips and tricks. And our discussants today are Jorge Ioa and Demetrius Kanathanasis. Everybody is very well experienced in this portion of glue ablation. So I'm going to turn it right over to Kathleen, and thank you very much.
Thank you for having me. I'm excited to be here with you today. I'm going to try to share my screen here and going to talk to you about some of my experience using cyanoacrylate glue and things we've learned and tips and tricks to avoid complications. These are my disclosures. So really, it's all about patient selection. Just like a lot of things that we do, selecting the right patient and the right anatomy is the key to having success, I think, with this technique. So what is the right patient? Anatomically, the truncal saphenous incompetence is what we typically are using glue for. And the IFU has such that we keep the tip of the glue where we start the ablation back from the saphofemoral or saphopopliteal junction because some of the glue can go forward and you don't want it to get into the deep vein. So if you have a very short segment you're closing, it's really not worth it to pull out a glue catheter and close like a 5-centimeter segment. You really should have enough, in my experience, about 10 centimeters that you want to treat back from the saphofemoral junction at a minimum to make this make any sense, especially financially. The patient should have no history of adhesive or cyanoacrylate allergies. Other products that cyanoacrylate is in include some of the cosmetic products to put nails on skin artificial nails, super glue, crazy glue, some modeling glue, things like that. If somebody's had an adverse reaction, ask about that. The patient needs to be accepting that this is a permanent implant. You should never sell this to a patient. You should discuss it with them and make sure that they're okay with it. And then ideally, the segment, in my experience, the ones that are right under fascia, at first when this came out, we thought this is going to be great because we don't need to worry about thermal injury. But they feel a cord under there if it's out of fascia, and it does go away eventually, but it takes a really long time. So I prefer doing phlebectomy for veins that are right under the fascia. So here's a patient that would be anatomically inappropriate. This person has an anterior saphenous vein that is very short and then has this long courseway of these varices. So there's really no place for using cyanoacrylate, in my opinion, in this patient. So what I thought was the ideal patient has changed. So when this first came out, I thought, okay, this is going to be really great for my young, active, healthy patients that want to leave the clinic with a Band-Aid on their leg, don't want to wear stockings because you don't need it after this, and they want to get right to the gym. So primarily C2 patients. Now my vision of this has changed. This is who I think the ideal patient is now. This is an elderly person who has limited mobility, really can't put a stocking on. Their skin is thin. They bruise whenever you're doing something like tumescent anesthesia. And a lot of them are on blood thinners. And getting back to mobility right away is very important in these elderly patients. And having something where they can get back to that right away is great. And we've also found in our practice over time that these patients have lower risk of hypersensitivity, in my opinion, and kind of so the data from our clinic than patients that are under 40. So I think it's ideal for elderly patients. So the two things that we're trying to avoid, one of them we know a lot about now and one we don't. And the first one is hypersensitivity. The second one is granulomas. So we first noticed in the VCLOS trial that this what looked like a phlebitis, but it was really different than phlebitis because it was red and itchy and usually not as painful. We first noticed this in the VCLOS and WAVES trials, and this was self-limited cutaneous dermal reaction, which occurred in the first several weeks after the procedure, and it was different than phlebitis. We found in the WAVES trial that we did in our clinic, which was 50 patients of various SEEP classes and sizes, that the patients with this reaction did not have an impact on return to work or normal activities or pain scores at a month, but it did at a week. So it bothered them for a week or so, but didn't usually keep them from working. And currently, we only have case series that document the incidence and severity of these reactions. However, The Spectrum trial that's coming out, it's been presented on podium and will be published soon, does have very similar hypersensitivity rates to what we see in large case series. So we think it's pretty consistent. So our definitions of hypersensitivity is it's a distinctive dermal reaction with erythema, itching, and variable edema or pain. So for me, the hallmark is it's itchy. If it's not itchy, it's more likely just garden variety phlebitis, like you can get with any sort of vein procedure. If it's mild, this is an example of a mild reaction. She looks kind of rosy on the inside of her leg. Really, you sometimes just need to reassure the patient, but typically I'll do over-the-counter medications like an antihistamine, an oral antihistamine, non-steroidal anti-inflammatories, and a hydrocortisone, a topical cream. A moderate or very itchy reaction, you may want to do a short course of oral steroids. Usually we do something in the US called a Medrol dose pack, which is a 6-day taper of a Solumedrol. Other countries may have it branded under a different name, but anyway, it's a steroid taper over 6 days. If it's severe or recurring or lasting more than 30 days, then this could require a kind of modified vein stripping to remove the vein. And since 2016, I've had to do this only one time. And that was very early on in our experience. So some literature reports, they vary a little bit in terms of the percentage of hypersensitivity. And so this is our case series of 367 limbs where we had a 6% hypersensitivity rate, and then 2 other ones that were a more Asian population. And this is kind of interesting because the Spectrum trial, which has been presented on podium, found that in the endothermal versus cyanoacrylate randomized trial, which was predominantly Western enrolled, Europe and the US, the hypersensitivity rate was about like what we saw in our series, whereas the stripping versus cyanoacrylate randomized trial, which most of the patients were Korean, had a higher hypersensitivity rate. So what we don't know is, are we defining it differently in different places? Are there epigenetic factors or are there anatomic factors that this difference seems consistent across the literature? So I'm going to talk to you a little bit about what we did in our trial of the 367 limbs to try to dive into hypersensitivity. So this is published data, but then I'm also going to talk to you about some unpublished kind of observations from my practice. So again, this was the one where we found a 6% hypersensitivity rate. We had one severe case, that's the vein that we removed that I mentioned earlier, moderate and mild here. And we interestingly did not find that having venous seal kind of primed somebody to then have it in the other leg. It wasn't more common when you did the second limb, and that was something we were concerned about. So we then did procedural characteristic differences, and we really didn't find anything. However, the way we looked at age in this study was as a continuous variable, and kind of looking at, and this is where I'm talking about unpublished data from more patients in our practice, if you put them into kind of cut point age groups rather than looking at it continuously, we found that over the age of about 70, 75, we see very low hypersensitivity rates, and we have higher hypersensitivity rates in the age groups under 40. So that might inform what we advise our patients when we see them, is kind of this difference that we don't see this as much in the elderly. But otherwise, we did not find anatomic, gender, et cetera, differences. So we have found, however, that our hypersensitivity rate when we track it was around 5%, 6%. When we did the clinical trials, it bumped up after this was FDA approved because we were using it more liberally. And then it came back down to under 5%, and we're doing some things differently that I think are responsible for that. Number one, we're screening for adhesive allergy. For example, the patient that had the vein removed, when we went back and talked to her, she was, all kinds of red flags for having reaction, allergic to Band-Aids, all sorts of things that we never should have put cyanoacrylate in her leg. So we do kind of questioning for every patient. We wait a full 30 seconds after the last injection before we remove the catheter, and we slide the blue sheath over the glue catheter. Or you can keep the blue sheath in and pull the glue catheter back in. We never want to have glue in the subcutaneous tissue. When this first came out, we thought, this is great. We're going to seal the hole with a little glue. And that's exactly the wrong thing to do because we've got a lot of immune cells in our dermis. So we now make sure that we keep the glue in the vein. And then skin testing has not been validated. There's been no studies showing that this works. But I have to admit, we sometimes do it with cyanoacrylate. And if the thing is, if you do it, you have to respect it and say, okay, if they have a reaction, I'm not giving them glue. So this is typically in people where I have a little bit of a concern and they say, no, I really want it. And I'm like, okay, I'm going to put this on your skin, see what happens. If they react, don't give them glue. So managing hypersensitivity, this is the consensus statement that came out that was published in Endovascular Today, published by Eri Fukaya. So if the patient has mild hypersensitivity, antihistamines, NSAIDs, topical corticosteroids, and cold compresses are recommended. If that resolves, great. And if not, a short steroid taper. And this is exactly what we do in our clinic. If that doesn't resolve, an additional or longer steroid course, or maybe you'll want to go with a higher dose. And if that doesn't resolve, you may want to consult with somebody that has some immune experience, a dermatologist, allergist, immunologist, and kind of last resort would be to remove the vein. Although that being said, if you do open vein surgery ever, it's really not that hard to take the vein out. You just have to be very, very careful to minimize your incisions to have a good cosmetic result. So the next adverse result of interest is granuloma. This is a picture of a granuloma at an exit site. So this is just kind of like a splinter of glue at the exit site that doesn't heal. Sometimes you get a little infection here, redness, just this non-healing spot. And then this is after excision. If you take the glue out, it helps it right away. Now, what I have not had in my practice is there have been reports of granulomas erupting along the course of the vein at later dates. That is a bad result if that happens. It's rare enough that we don't have data to know why it happens. But my theory, which again, unsupported by data, is that it is when there is glue outside of the vein. So whether it's when the wire goes up to put the sheath in, the vein is punctured, whether there's too much pressure on the leg when the vein is being compressed. I think that there is some probably trauma to the vein because when these have been excised, the granulomas are outside of the vessel. So, we don't know why, but I'd say be gentle with the vein and do your best not to have that happen. That's my best advice on that. So hopefully we have a little time to talk really quickly about another study. This one has been accepted for publication in the Vascular Medicine Journal, but it's in revision because they gave me 3 pages of changes they want me to make. So I don't know when you'll see it, but this has been preliminarily expected. This was a review where we looked at 327 matched patients, matched by date, that had endothermal ablation versus cyanoacrylate, and we were looking at side effects and things like that, what they had, and this is the adverse events. So the number of adverse events were very similar, 62 and 70, no difference in the number, but the types of adverse events were different, and this was interesting. So first, endothermal ablation. We had more thrombotic events, both DVTs in the calf and EHITs. We had adverse events related to stockings, because we put our patients in stockings, and this may inform maybe we should do that better. Infection and wound draining issue, because these patients, more of them had phlebectomy than those in the venous seal group. So that's probably why we had these wound healing, and then some nerve injuries. In the venous seal group, we had more phlebitis, and we see these in clinical trials too, that kind of inflammation of treated veins or branches is a little more common in venous seal. And we had hypersensitivity. Of course, that does not occur in endothermal ablation, and one subcutaneous glue at an exit site that needed to be excised. So the difference in events was interesting. So to summarize, when do I prefer to use cyanoacrylate? Or I guess this isn't a summary, this is more tips. When it's below the knee great saphenous vein, and I'm not planning to use Varithena primarily, I like it. I like it in the small saphenous vein just for the nerve injury issue. I really like it in needle phobic or low pain tolerance patients, and it's my treatment of choice in the elderly. So this is an elderly woman before and after venous seal that was, as you can see, the walker over here, quite in the background to help us know she's elderly, very debilitated in terms of mobility. It was nice for her. So to summarize, it's an innovative treatment, but it's just one of our tools, and you need to know when to use it. Patient selection is critical. Proper anatomy is critical. You should recognize hypersensitivity, talk about it with your patients beforehand, show them pictures just like I showed you, so that they know what it is and they don't get freaked out about it, and you have a treatment plan if it occurs. And it has a particular advantage, in my opinion, in certain patient populations. Thanks.
Thank you very much, Kathleen. I do have questions for you, but I'm going to hold those to the end. Basically on EJIT and TCAC, we'll go forward with that. Demetrius, the floor is yours. Comments, questions?
Well, thanks for the talk. Great talk, Kathy. And that, in my opinion, the only thing that I will add in this lecture is the skills for ultrasound. Many of the adverse reactions are because they're injecting outside the vein and they cannot, identify the target vein. Probably because they have low quality equipments, low quality ultrasound, low skills. So I think this is the basic for having adverse reactions. And then probably, in my opinion, side branches and very superficial veins are not likely to be treated with this technique. I prefer phlebectomies and sometimes, combined scleral and phlebectomies for the largest veins. This is my address, my opinion, and I would like to hear also the other discussants here.
Thank you very much, Demetrius. Jorge?
There is a couple of things that Kathleen just mentioned, which I think it's going to be pivotal to understand the advantages of this procedure. There's many options out there. Patients are very well aware of what we can offer them, and they usually come to our office asking and demanding for a specific type of procedure. But elderly patients, I think they get benefit of it due to the serious difficulties that we have and face with the use of compression stockings. And the second one is that one. Compression stockings is something that day by day we see patients being more reluctant to use it. And the real advantage of using compression stockings in other therapeutical options that we offer them is really something that I think that it needs more debate. I'm not pretty sure that we are doing, as the producers of those compression stockings are saying, that we need to do that because that's going to be an advantage. Therefore, maybe, and that's just speculation, in the future, we're going to see less and less thermal ablation without the usage of compression stockings with the same results. That's just something that I put on the table for you guys to destroy me in academic settings in the near future. But so far, I think that Kathleen has a point with that. I'm a little concerned about something that has been addressed in a very timid way, which is the possibility and the option of having in the next 20 or 30 years Asia syndrome with these kind of patients. That really raised my eyebrows when I got the option of offering this in young patients. Therefore, I think the choosing, and one of the first slides that Kathleen mentioned and made a point, is the use on elderly patients, I think is clever and it's of pivotal interest.
So academically, Jorge, thank you very much. I'm not sure there's a whole lot of evidence for compression and thermal ablation these days, so I'm not concerned with that. There is a question here, and I'll open us up to the panel. There was a paper, as we know, from Karush Parsi that basically talked about the adverse events of cyanoacrylate. Kathleen, also Professor Nuttawat from Bangkok also talked about the incidence of EJIT, which is just glue in the deep system, as well as TCAC, which is thrombus extension. and they were all about 4 or 5%. And noticed in your personal series, it was really, really low. Are you doing something different than the masses are?
I think I am actually. And Demetrius kind of pointed this out. We've got really, really good ultrasound. And I don't use RVTs to help me when I do endothermal ablation or Varithena. I do it by myself. When I do VenaSeal, I have an RVT there because I really want to control the glue. And we're using our ultrasounds that we use to do all our diagnostic studies. So I have a very good ultrasound. I'm very careful about compression at the junction, and I follow the IFU. I've seen people that say, okay, no, it's going to be a problem. You're going to get recurrence up, because you're too far away. I respect the junction, and so I think that that's why my rate of extension is really low. And we have another paper that I will be submitting this week that is our kind of waves extension trial, and we did not have an increase in recurrence at 3 and 5 years of recurrent disease compared to what we traditionally see with endothermal ablation. I think they're the same. So I think that that's probably really good ultrasound, an extra set of hands. Not everyone can have that, I know, but again, and then respect the junction.
So with that being said, if you have a smaller vein, I mean, the standard is 5 centimeters, correct?
Yep.
If you have a smaller vein, are you worried about toothpasting? Um,
Yeah,
so
I
would
mean,
you?
yeah. I tend not to
Uh,
use it as much in like a smaller vein. I tend to use other techniques. I'm more likely to use Varithena in a small vein. If someone's got like a 4 millimeter refluxing vein, I actually really like to use foam, or thermal. But I think that the also cyanoacrylate, it's expensive in the US too. And for me, that the vein needs to deserve it, if that makes any sense. It needs to be kind of the procedure that I think is really going to work, where I think a little vein, your concern or your thought about it toothpasting is valid, because the click it's 0.1. You can't change it. You can't do half a click. Um,
So do you
yeah.
change with the idea? Well, you use a different ablative technique, basically for smaller veins. Um, for larger veins, I know the wave study and what you've done. Are you going forward more than closer than 5 centimeters, or are you just sticking with that?
So you mean doing closer? No, I go 5 centimeters from the junction, kind of no matter
Okay.
what. I just do it the same way every time. I'm getting old enough that I like doing it the same way every time for a lot of things. Breakfast, what I eat at lunch, this.
Why,
So
Lowell? Why are you getting closer?
That's a question for you. Remember, when you ask a question, you get it back from the host.
No,
So
well,
the reason
that's a good
for that
technique.
question.
That's a beautiful technique. I don't mind. I mean, I think the rule of going with laser for 2 centimeters, 1 centimeter below, 5 with glue, I think it's you can do fantastically well doing any kind of occlusion 5, 6, 7, 10 centimeters below. I don't think that there is enough evidence to support that we're going to have a higher recurrence rate by leaving a long stump with these kind of techniques. It happens before with in the surgical age, but not anymore. I don't think it's going to be something. Well, it will need to be studied in order
Actually, there is some
to.
data out there looking at the recurrence of anterior saphenous vein. We'll bring that up at a later date because there is some thought of actually treating non-refluxing. I'm not a big fan of it, so we'll go into that a little bit in the future. There are some ideas about ground zero ablating, and I think you have to be careful in what thermal ablation technique you're using, as well as if you're using laser, what kind of fiber you're using. And
Yeah.
I think that the question is, so what? The question is, if you have anterior saphenous recurrence and no symptoms, what is it? So anyway, there's one last question, and I don't know if anybody has the experience of using Turkish glue. Anil Hingorani asked that question, what is the comparison? Is there any difference in terms of complications, et cetera?
So, and I think that there's another good point here that Kursat brought up is that that 5 centimeters back IFU is for venous seal. It's not Turkish glue. I believe the IFU, it's closer. And those
Right.
glues, while they're both cyanoacrylate, and you might say they're cousins or sisters, they have different viscosity and the technique is different. So I think we need to be careful when we're conflating one with the other, personally.
100%.
And I do know that kind of there is less randomized trial evidence, I believe, for Turkish glue, but I believe most of the published reports, there's a lower hypersensitivity rate than with venous seal, and I don't know that anybody knows why. I think the only way you could tell they're truly different is if you put them head to head, right? Otherwise we're just kind of extrapolating from different studies different people did. But
Kathleen, that may happen.
Yeah, yeah.
I think you summarized Kursat. It's got a different curing rate as well. It's very quick, as you mentioned. So there are some differences there. We have about 5 minutes left. I don't know if Kursat can join us. I know that he's on a panel. I know he's at another meeting. If he can sign on, that would be great. I see him coming on.
There he is.
Oh, he's driving.
It's in the dark.
No, not really. Do you see me?
Yes.
Yeah.
Very well.
No, I'm not driving. I'm just waiting in my parking place. So, Kathleen, it was a fantastic presentation. I enjoyed too much. Honestly, you are a very great speaker. I totally agree with you. I mean, we should be very careful when you are using glue, both glues, Venasil or Venablock, doesn't matter. But crush paper is just the problem, we wrote several letters to Phlebology Journal, and it's exaggerated paper. Definitely both Venasil and both Vericlose are doing good job. Venablock are doing good job. There's no question about that. But only one thing, I usually like Jorge to be close to the saphenophyseal junction. I strongly believe it may reduce anterior saphenous vein recurrence. Definitely, I strongly believe in. So actually, these are all, I just want to comment on that.
Well, thank you very much, Kursat, for joining us in the parking lot. That's very nice of you. We don't have very much time, but I wanted to mention that there are physicians, Kathleen, Kursat, that are starting to treat, and I think Demetrios is also treating perforating veins. So be aware that's on the horizon. Next week, we're fortunate enough to have Michael Sadik, and he's going to be talking about thermal devices, where we are, where we were, and now where will we go. And that looks pretty interesting. And Michael Vasquez and Olivia Pichot will be discussants. And I'd like to thank Kathleen and Demetrios and Jorge for joining us at Vein and Lymphatic University. And we'll see you on December 3rd for our next grand rounds. So everybody that's in the United States or those that are looking to help celebrate, happy Thanksgiving.
Same to
Thank
you.
you.
Thank
Thanks
you.
for the invitation. Nice to
Thank
see
you.
everyone.